Hi, Emma. Oh, have we got you on mute? I think we've got you on mute. Is that us? Is that us doing that? It wouldn't really be Journal Club if there wasn't some minor technical difficulty to begin with. So do bear with us. it makes everybody feel more comfortable if we just take a few minutes to get settled in. Apparently my daughter's currently screaming at me on the iPad. Hi, Beth. Yeah, all good fun, right? We will get started just shortly. I'm not alone in here, but I'm not alone at the Royal College. It does. I'm sure it does look that way. You can almost see a coffee cup on the other side of the table as everybody else is scarping to the other side of the table to avoid the limelight here. We've got one viewer currently one viewer. I think it might be Beth. So.
Never too young to learn.
Indeed, about medical grade footwear. So. So I'm going to start screen sharing, Emma. Now the only thing is, somebody else joining us. And then it disappeared again. I'm going to start screen sharing because I have a series of questions. I sent you them earlier, so you had some chance perhaps to look at them. But we'll use that as a kind of guide to try and keep us on track tonight. The one thing that nobody likes at Journal Club is for it to go on too long. So we'll try and do that. So I'm going to screen share. The only thing is, Emma, when I'm doing that, I can't see you. So if you want to message me on my phone or something, then or if you don't get the mic sorted out. So. Oh, there we go.
Okay, I've plugged in a microphone. Can you hear me now?
Yeah, that's perfect, Emma. We can hear you.
Great.
Right. So have Emma Cowley in Plymouth, myself, and some students who are hiding in the corner there. You're not hiding too far away. I can turn this laptop around in just a second. So this evening we're going to be talking about Hurst et al. It's an article published this year, 2017. So couldn't get more current than this. And it's medical grade footwear, the impact of fit and comfort. It was published in the Journal of Foot and Ankle Research, which is one of our favorite journals here at the Journal Club, as it's closely attuned to our interests, and also open access, which means we can all read the article before the session. So that's good. That's our introduction to the article. So the first thing that I thought we would probably talk about is first impressions of the article. Well, what do we know about the journal? As I say, it's one that we've covered before, so I don't think we should spend too much time on that, but it's the Journal of Foot and Ankle Research, who helpfully retweeted that we were going to be talking about this this evening, so that was nice. What do we know about the authors? The authors, I've put on the first slide there that it was Hurst et al., but it was Bessie, Hurst, Helen Branthwaite, Andrew Greenhall, and Natchipan Chocklingham, who are based in Staffordshire and are well known for their work in.
I can comment here very clearly because I used to work with them. I was in the same office.
That's right, okay.
And Helen.
They're prolific researchers, I think I would say. And this is their area of interest generally. So that's interesting. Is this research of interest to the podiatry audience? I'll throw that one out. What do you think?
Absolutely.
As a future podiatrist,
yes,
were you interested? When you saw this, did you think, oh, this is something that I'd like to read? I think I did as well. Emma, your thoughts when you first saw this?
Okay, so yeah, I should declare that I was a reviewer for this paper.
Yes,
so I have read it before.
So it'd be that aside, when you first saw a subject you were interested in, I take it?
Absolutely, yeah. I mean, the thing that was notable to me was that the first two authors are podiatrists and the latter two are bioengineers. So I was interested that this would possibly have a slightly different twist to it, not just a purely clinical twist, but it might have something perhaps a little bit more on the engineering side of things to offer as well. But when I went on to read, it seemed that they had pretty much actually stuck to a very clinical measures, and I thought it would be of interest to the profession for sure.
Yeah, no, definitely. Anybody that I spoke to about the topic for tonight's journal club, they were interested in it. So yeah, it was definitely a good choice of area for research. Now, is it original, would you say? Well,
they say it is.
They say it is. Well, I would say, well, perhaps I don't read the right journals, but for me, it's not the type of thing that I read very often. So it does seem fairly original. Emma, just.
Yeah, for sure. I think in the world of sports footwear, there are similar studies more relating to comfort of fit and performance, and that comes through Ben O'Nigg's group. But certainly in terms of medical grade footwear, the only other one I can think of is, oh gosh, it's late in the day, Salford. Oh, name's on the tip of my tongue, sorry. Anita Williams, who has published extensively on rheumatoid patients and the uptake of wear of prescription orthopedic shoes, and perhaps that isn't as ideal as is intended, and possibly that might be down to the impact of comfort and fit. Yes.
Oh, and incidentally, shortly before the journal club, I went across to the college library upstairs, and they have a textbook, Therapeutic Footwear, a Comprehensive Guide, by Wendy Tyrrell and Gwenda Carter, published back in 2009, which is quite interesting. Not original research in this sense, but on a similar theme, which was nice to read before the journal club this evening. Yeah, so original. Is it when you read the abstract for this particular article, did you all think this was a good summary of the article? I thought it was.
Yeah.
And do you think it fits well with the title of the paper? Before we go any further, title of the paper, medical grade footwear, is not a term that I was particularly familiar with before reading this. I get the inference of what it means. Is that terminology used around about Plymouth?
Not particularly, not especially. I think we would tend to refer to therapeutic footwear as per Wendy Tyrrell's book, as you've just noted. And within that, maybe even orthopedic footwear as well. But of course, I think what they're pointing out here is that this is intended for medical use, footwear intended for medical use, or as part of a care plan for people with conditions requiring it.
When I googled medical grade footwear to see what came up, and the results were predominantly Australian. So I don't know if it's a term they're more commonly used in Australia. But
none of the authors are Australian, so I don't know that.
Well, yeah, they're from as you say, they're from Staffordshire, but that term seems to be more common. At least from that Google search. Crikey, that's
must be right.
If it's not on Google, can't trust anything these days. So, having read the abstract, did you think it fitted well with the title? I think, are we agreeing that was the case? Yes, I think so. The impact of fit and comfort, yeah, indeed. So, what was the purpose of the article?
To see if this type of footwear has an impact on the pressures of foot experiences.
Well, that's one of the things they measured, certainly. They were looking predominantly at the comfort and the fit. What was the purpose? Yeah. And when you were reading the introduction, did you think there was adequate information given in as background to give us some perspective on where this sits within the broader footwear research? There's comment in the introduction about the issue of trying to get people to try and encourage people to wear prescription footwear, high dissatisfaction with prescription footwear. I was having a wee flick through that therapeutic footwear textbook before coming over here. They were talking about concordance, trying to encourage people to wear the shoes that are recommended for them by health professionals, allied health professionals, doctors, and others. I think the attempt here is that these Dr. Comfort shoes might be more acceptable. I did look these up because the Dr. Comfort shoes, be careful, haven't we, when we start talking about products? We're not trying to sell these. I have no shares with this company. But it said here in the reference that they're in the USA, so I did wonder if they even have them here, but they do. They do seem to be stocked in the UK. So,
yeah, they're stock footwear.
Yeah, so they are available, and they name them Brian or Annie. It's unusual. They seem to have a whole range based on people's forenames. So yeah, where was I going with that? The concordance can be an issue.
What I liked about it as well was that they were basically seeking to compare an objective measure compared to a subjective measure. So it would actually possibly be useful in patient education if you could show and demonstrate the increase in dorsal pressures, which in itself is quite unusual to measure, and correlate that sort of within the clinical situation to what the patient's complaining of in terms of pain in their own shoes, for example.
Yes, that's true, and you're hitting something there that I was thinking about earlier on. They usually look at plantar pressures.
Yeah.
Dorsal pressure was rather unusual. So when I looked up this walk-in sense device, does that what we call walk-in sense sensor placement? Yeah. When I was looking at that earlier on, it does seem to have been used more in plantar pressure rather than dorsal pressure. So yeah, that was interesting as well.
Can I just ask?
Yeah,
but it's just, although it says it's measuring dorsal pressure, quite a few of the sensors are interdigital. You know, and
well, I think we'll come back to that
Okay.
when we get to the methodology, because I had some questions on that as well, actually. So yeah, so let's not eat up all our time on the introduction. So the purpose of the article, I think, is reasonably clear, and the adequate background, I think, yeah, by and large, we were quite happy with that. So we'll skip that. Methods: is it possible to replicate the research based on the information that has been provided? Could you do this again? I wasn't sure that I could, to be quite honest.
Well, I think the pictures are very helpful.
The pictures are helpful. Now, don't get me wrong. I've never used this walk-in sensor placement idea. I've not really had much to do with that kind of technology at all. But I was looking at it, and there's the bit where they describe that, the in-shoe pressure system, and they describe the placement of it. Now, it says 1, 2, 3, 4, 5, 6. Medial border of the first entry joint is quite clear on the diagram. The medial border of the first interphalangeal joint, again, pretty clear. Interdigital, and it sort of infers then between first, second, third, fourth, fifth, pretty clear. Proximal interphalangeal joint, wasn't sure which one they meant, or if they meant all of them. Fifth proximal interphalangeal joint, because it was the middle one, the proximal. Yeah, this is one that I was having trouble with when I was looking at it earlier on. I would have thought, you know, is it the second PIP joint that they're looking at, or is it actually all of them? Or does the one sensor cover both the interdigital and the, you know, can they get two readings from it or something? So I wasn't particularly clear on that point, but as I say, I'm not really familiar with the technology. So
yeah, if you look at the photographs, I think that does help to clarify slightly what they mean.
Have you used this, Emma?
No, I haven't. No.
I've not used it. I don't really use anything like this. Have you seen this used? Because I know that in the research department at the uni, they sometimes use things like this. Okay, well, that was one thing that I certainly was a bit unclear on. The pictures are helpful, certainly. Okay, what else did they say? What did we think of the sample size?
There was no power calculation in the first iteration of this, and it was something that one of the other reviewers commented on. These are freely, openly available comments, so I'm not breaching any confidence here. It's all written up as a as part of the publication on the website, and they justified it as having been sort of fit for purpose given previous similar studies. So they didn't go on to declare a new power calculation or anything. So I'm not quite sure what their a priori data was to inform their sample size.
Well, I'll tell you one of the things that jumped out at me. Selecting the article for Journal Club. Now, I always say to everybody, send me your suggestions for an article for the Journal Club. And of course, nobody ever sends me a suggestion for an article for the Journal Club. So then I go trawling the internet looking for something that we can talk about, and invariably head to the Journal of Foot and Ankle Research. I do like it, and it was one of the editor's picks was this medical grade footwear. So I had a wee quick look at it, and one of the first things that jumped out at me was the fact that they'd actually done this using patients from private practice. So 30 participants, all from podiatry patients, recruited from a UK private podiatry clinic. And I rather liked that because we often think of research being undertaken within universities or within NHS departments, and the idea that there's a combination, obviously, between the university and but selecting their patients from within private practice was...
I'm not sure if it was the same private practice, because both the first and second author run private practices. Again, Googleable.
Oh, well, that wasn't. Well, that's interesting. I hadn't picked up on that. Nevertheless, selecting the patients via private practice was great. Yeah, it was quite good. So it seemed like quite a small sample. So as with all these things, you're kind of wary of taking too much away from this, but presumably the numbers I had to work with, though. Then just immediately after that, I see the ethical approval was sought and granted, so that's always reassuring. Participants were included in the study if they were male or female above 50 years of age, which kind of fits with the sort of normal patient group we'd expect to see, I think, in podiatry clinics generally, obviously with exceptions, and certainly in the right kind of age group for patients who might require medical grade footwear more often than not. So I thought the sample was okay. They had. I'm looking for the exclusions here. Participants were included, including hallux valgus and lesser toe deformities, but not exclusive to hallux valgus or lesser toe deformities. And you would think that would be it would be interesting to do the research simply looking at people with hallux valgus or forefoot deformities like that, and perhaps even looking at them with a sort of grading of hallux valgus or something to give us a better idea of how that would play out in those populations rather than a kind of more general population. But it is what it is, isn't it? The footwear was outlined as the specific shoes, and it was a male variant and a female variant, but they look very similar actually to mine.
Very good season, Alan. You wouldn't understand.
I'm sure there's some subtle difference. I wasn't. With footwear, of course, there's the patients when they were looking at these patients, they of course arrived with their own footwear, which was a wide variety from what they tell us here, and your own choice of footwear is probably really important. When we go back to that kind of issue of choosing to wear the shoes, agreeing to wear them, even if it's kind of medical shoes or whatever. Kind of looking at that would be interesting. One of the things that popped out at me was the weight of the shoes is clearly listed here. We have a very specific weight for the medical grade shoes. They didn't weigh the shoes that the participants brought themselves. If the weight of the shoes is particularly important, it might have been interesting to see what the difference was between the weight of the ones they tend to wear and the medical shoes. Are they particularly heavier or lighter, and did that make any difference? Perhaps not. I don't know, but it stuck out that was there. Okay, what else have we got? So they appeared in a range of footwears. We've got what we got here: leather boots, court shoes, lace ups, and so on. with no defined medical features. Okay, so that was their existing shoes, and these were used as a comparison in the study. And as I said, I don't have any experience with these in-shoe pressure systems, so I don't think we'll stray into too much detail on that. But the data collection included a comfort measure. The patients were allowed a familiarization period. It doesn't actually say how long that was. I'm not sure how long it takes to get familiar with a pair of shoes. It varies for me. Sometimes, sometimes they feel very comfortable within the first hour, and other times it can take longer. So familiarization period, nevertheless, allocated to the participants who then walked along a 6-meter walkway at self-selected speed. So in the intervention shoe and then in their own shoe in a randomized order. Am I coming through okay, Emma?
Yeah, absolutely fine, thanks.
And then they were asked to rate the comfort using a 150mm visual analog comfort scale. Is it not more common to use a 10mm?
Yeah.
Why 150? That was odd.
But it's nice because it more easily would force you one way or the other, maybe.
You think
well, I don't know. I seem to always be able to get my dot right on the 5 centimeter mark. Ask me any question, 5 centimeters. Yeah.
You can hedge your bets. Yeah.
But there is some evidence to suggest that numerical rating scales are more accurate, or at least more closely reflecting the true level of pain. I think it's probably more easy to relate to a number out of 10 rather than a period along a line. I don't know. Yeah.
So, yeah, 150mm visual analog comfort scale covering 9 themes of footwear comfort. Overall comfort, heel cushioning, forefoot cushioning, side-to-side support. And what you wonder when you're reading this, if these terms were all particularly familiar to the participants.
Yeah.
You know, were they able to differentiate between all these different features themselves? Some of them are a bit more obvious, I suppose, heel height and forefoot width and shoe length. And shoe length seemed to be important in the end when they looked at the results. How easy was it for patients to differentiate between these different features, or subjects in this case, to differentiate between the different features? Specific words that most clearly delineated extremes were anchored at the ends of the scale. So not comfortable at all was 0 points, and most comfortable imaginable, 15 comfort points. 15 comfort points for the most comfortable imaginable.
I want those shoes.
Me too.
These are potentially the holy grail of shoes. Right?
Yes.
So we'll keep our eyes peeled for that in the future. So these were really the two things then. So the comfort measurement and the in-shoe pressure systems. And then they moved on to the statistical analysis of each characteristic. Everybody draws breath at the same time. You're ready to talk stats. And what did they use? Kruskal-Wallis test.
Yes.
Yes. Everyone's nodding. We approve of the testing that's been done here. In-shoe pressure system. I'm getting lost in the article here. Where are we? Pressure data. Okay, so let's get to the results. What are the results got to tell us? Oh, here, I forget my slides now. There we go. So, any flaws with the tables or illustrations? I didn't pick up on any flaws at all with the tables or illustrations.
Perhaps we could just go back to the stats just very briefly. I don't want to become a terrible bore, but it is something that I think we need to probably address, because the data appeared to come out as non-normally distributed, and so non-parametric test, the Kruskal-Wallis test, was selected as a non-parametric ANOVA. But then they've used t-tests for the others. So they've got parametric tests on one and non-parametric tests on another. And it was suggested one of the solutions to this, it's obviously ideal to use parametric tests over non-parametric. Non-parametric tests tend to rank data, so it's not quite as accurate. It doesn't give you, it'll compare pairs to each other when you're comparing a mean, but it won't give you the difference between the ranks of each of the pairs going down the scale. So what the suggestion can be in this case is to transform the data so that it comes out as normally distributed. It comes out nearer to a regression line, and then you can apply parametric tests. Now, I know I'm getting heavy and I don't mean to, but the point is that it was suggested, and the review and the authors came back and said that actually they felt that it wasn't best done to pressure data. Log transformation wasn't. Sorry, my Hey Siri has just kicked off. Log transforming pressure data was not a good thing to do to pressure data, but they didn't say why. So I'm still at a little bit of a loss why they've elected to choose a slightly less powerful test when actually they had the opportunity to do a more powerful test, and whether it might have even changed the results. But I will leave it there and we can move on.
No, that was interesting. Thanks, Emma. Now, results. So we said before, any flaws with the tables or illustrations? I'm not aware of any, if there are any. All of your to be in order. There's 3 graphs that show us various features: mean peak pressure, time to peak pressure, and mean contact time across the different sensors, the 8 sensors. And then, of course, we have a table at the start talking about the different features from the comfort scale that they use, the comfort perceptions. And from this comfort perception, the length of the shoe seemed to be the most important of the features to the subjects, to the subjects in this particular research. Which is interesting because, well, would you have expected that?
In women, maybe, because I hadn't realised till I was doing this course how people wear shoes that are too small to make their feet look small, which is like the oddest concept to me.
That is odd, isn't it?
But you see it all the time. Yeah.
Well,
Yeah, it's certainly well documented in women's shoes, not so much in men's shoes, but certainly in women.
I kind of thought that it would be the forefoot, the width and depth, and so on. The forefoot would be of more interest. Wasn't really thinking the heel height would make much difference. But the length, yeah, there you go. So. And then moving on, do you feel the information is presented clearly? Were these graphs easy to understand? Mean peak pressure.
Is it too complicated for someone to quickly explain them? I meant to look at that. Because I look at them and I can see which one there's most difference, but I don't know how to tell whether it's so important or not.
Well, on the graphs that we have here, relate either to the person's own footwear or to the medical grade footwear, and they're looking at the peak pressure. So you can be able to tell where the highest pressures were related to the different sensors that they used, so the 8 different sensors. So it would appear to be highest in sensor 6 and a little bit less in sensor 8 in their own footwear. In the medical grade footwear, you can see there's a reduction. Now the line coming at the top relates to the standard deviation, and I'm trying to see on this. So for the mean peak pressure, what was the lowest for the medical grade footwear? It was sensor 2. I would have to look back to see what sensor 2 was now.
What is this side of your
sensor 2 is side of your big toe. That's right. So that was the lowest in both their own footwear and medical grade footwear. Where was the biggest drop then? It was between sensor. Looks like sensor 7.
7 or 8, but that's it. How can we tell?
And which one's 7 or 8?
your fifth.
Oh, it's fifth. That's an outside foot, lateral border of the foot. Am I reading that, Emma? Is that how you see that too?
Yeah, absolutely. Yeah.
Okay, so that was the mean peak pressure over the time we're using it. The time to peak pressure, so how quickly it got to this peak pressure.
Perhaps I could just also just comment before you move on, Alan, just on the error bars, because the error bars indicate the standard deviation. This is the spread of the data effectively away from the mean. And the larger the standard deviation, the more variability there was in each of the samples. So where you're seeing a long line, it means that there were ranges coming in. So if we used height, for example, you'd have some people who were 2 foot tall and others that were 8 foot tall. And the mean might be 6 in the middle or something. I don't know, quickly doing some maths. But it might also be that you could get the same mean, but with a very small standard deviation either side of it. So the data is more closely packed around the mean.
Yeah.
So when you see large standard deviations, it normally reflects the population and the exclusion criteria. So where you're seeing a lot of variation, it normally means that you're drawing it from a wider population. Whether that would be absolutely the case here, I don't know. But bearing in mind they didn't do a power calculation, I would suggest that may be of interest. The data is quite variable.
Okay, thanks, Emma. That was good. Right. I was just checking the broadcast there. So on the live broadcast, it shows a slide when it's quiet or when we're talking here, but when Emma's talking, it actually shows Emma.
Oh, does it?
we can't see that from here. I've got it streaming on my phone as well, so I can see what's going on. I was trying to see if anyone else had joined in, but all we see is a slide. This is one of the difficulties with running it this way. But anyway, we'll stick with it for now. Where had we got to? Do you feel the information presented clearly? And we're talking about the tables, time to peak pressure. And then the last table was mean contact time, which seems to be a lot of variability with, going by these error bars, certainly. So I'm not sure if we can really tell much from that at all. Well, what did they say? Let's go back to the results and see how they summarized it. So look back at the mean peak pressure, and the highest peak pressure point was identified in sensor 6. Okay, that's what seemed to be the case from that diagram, but I'm not so sure with the others, so let's have a look at them. Overall, for mean time to peak pressure, overall 6 of the 8 anatomical regions demonstrated a large effect size. So that's why it's not particularly jumping out at us which one, because they all seem to be increasing. And mean contact time, 4 regions demonstrated a large effect size, so it was kind of more broad, a bit more broad there. Do the results fit with the objectives of the paper? I think they do, really. I think they do. They set out to look at comfort, and they set out to look at peak pressure, and they have managed to demonstrate what that would be, whether it's particularly meaningful or not, but they have managed to do that. Yeah, comfortable with that. Consider the author's interpretation of the results. Have they reached a logical conclusion? What did you think when you read through that section? Did you think that when you got into the discussion and sort of towards the conclusion section, did you think that what they were saying was reasonable?
But I would like to know if it had reduced. Really, I would like to know better where the sensors were for the toes, because actually reducing the pressure between the toes wouldn't correlate with particular pathology that we see. Whereas if those pressures were also monitoring the dorsal aspect of the digits, then that does correlate to something that we see a lot of, if that makes sense.
If the sensors were over areas that are known common problem sites, like where you have a hammer toe deformity or great shaping deformity.
Because then does it to say that when treating digital lesions associated with pressure, well, where on the digits?
Well, it says footwear comfort perception is largely subjective, which does make it really difficult to determine how to take any of the results round about comfort, doesn't it? And it might be impacted by other factors as well, other than just physically whether it was comfort, but whether they actually like the shoes or not.
Well, they do talk about, you know, even the smell of the shoes matter to people.
But it doesn't seem to think about how they'll fit in their own shoes, where the improvement could just be down to the medical grade shoes being
That's an interesting point, actually.
rather than the fact that they're medical grade in any special, particular way.
Yeah.
It could be just that they're well-fitting shoes.
It might have been worth asking them the same questions about comfort perception of their own shoes.
Yeah.
Since we were going to go to the trouble of measuring all the pressures and stuff, it might have been interesting.
Well,
maybe they didn't
we
find
did.
it. Maybe they didn't find their own
No,
shoes
we
particularly
did.
comfortable.
Didn't we ask them the same?
Oh, they did. Yeah.
Yeah.
Excuse me. Yes, they did. Own footwear versus the medical grade footwear. Yeah. No, my apologies. My apologies, authors. It is
If
there.
they're two sizes too small, then something that fits you is going to be more comfortable, isn't it?
Yes, it does talk about slightly improving the appearance of shoes. One fact that doesn't bring up here at all is there's an idea floats about that patients might value therapeutic type footwear more if they were charged for them.
And I think it's fantastic to consider that would be something that we would do, in that, I could say to someone, you could go and buy these shoes, they are shown to be more comfortable. That when you hear the number of people that say they don't use their very expensive provided shoes, then that would be great if they could go
severe with them
if they paid for them.
Having gone out and chosen and paid for their own footwear, would they be inclined to rate that higher than medical grade footwear if they hadn't been given them for free?
Yeah.
Interesting. Yeah.
And they could tell you in the shop whether or not they would agree to wear them. Whereas they get this shoe made, and it's only at that point when the shoe's no good to anyone else that they say, no, I can't wear that. And it's not their fault. They've not had the chance to try it on.
Mind you, can't ignore the possibility that some of these people with bunions and hammer toes and so on, if they were able to get this footwear to solve their pain and problems, certainly be a lot cheaper than surgery.
Yeah.
Which must come out at 30 or 40 times the price of this pair of shoes. So,
no time off work.
And no time off work and so on as well. So, it means it remains an interesting area, doesn't it? Their conclusion was there's minimal research on the efficacy of appropriate non-bespoke pressure relieving footwear, which clinicians can introduce to patients. I put on Twitter today, I'm going to just have a quick check. I did put on Twitter today, does anyone actually does anyone, where's the tweet gone? Crikey me. Right, where am I? Right, here we are. Right. Do you recommend any off-the-shelf medical grade footwear to your patients? Now, presumably most of the people that follow us on Twitter scratched their heads wondering what medical grade footwear was for starters. But once they got past that particular question, do you recommend it? Do you recommend it? Do you see, we see a lot of clinicians in practice, podiatric and others in practice, do you see them recommending particular footwear?
Well, the only person I know he would say to you, try. If you ask a question about us, well, I suppose it's not maybe medical grade stuff, but he would say, well, try different people, different feet, different shoes. Can't say that's the right shoe, but that's probably more sport that we're talking about.
I'm not sure that I ever recommend any particular, well, we don't recommend any particular brand of shoes, do we? Certainly not the NHS clinics generally, but we would tend to refer people through to an orthotic service where they would give them an opinion on whether they need bespoke footwear, whether they need, over the shelf. Off the shelf, the term I'm looking for, footwear. I suppose in private practice it probably works slightly differently, and we can recommend a particular type of footwear. Emma, what about current practice in England? Do you recommend any shoes in particular?
Well, bearing in mind this was done in private practice, I think this is a really helpful paper to people that don't have access to orthotic service provision shoes, because the Dr. Comfort footwear is of that grade, and although it's not modular footwear, you haven't got the opportunity to vary the dimensions of the forefoot per se. I think as a private practitioner, it's something that you might be really grateful to have the option for if you knew some data about it. The thing that's missing for me on this is that there's no correlation. It would have been lovely to see a nice correlation between the pressure changes and the perceived comfort changes. So they could have done a global pressure score, perhaps, or taken the highest pressure reduction or something like that, and correlated it to the perceived change in comfort, so that we could have actually really shown that pressure in these people who do have these toe deformities, comfort really can be altered by reducing the pressure over those areas. So yeah, I don't know really whether in the NHS in England it would be any different from Scotland. Certainly the trust I am affiliated with, we would use orthopaedic footwear provided by the orthotic department, the same as you. But certainly in private practice, I think this is a useful paper.
Yeah, absolutely. That's a very good point. And as I said before, I was rather drawn to this article because of the link with private practice. And I quite like to see that. So the limitations of the study. This is always one of the sort of closing points for most articles, to start to identify the limitations, and of course, as an extension to that is considering future research and what else can be done. I think Emma's just provided an example of something that future researchers might look at if they're going down this line. The limitations that they identified: the potential for bias by not blinding the researcher or participant to footwear condition, as it may have influenced subjective scoring. I have to read that twice to understand that. Hold on a second. The limitations of this study include the potential for bias by not blinding the researcher or participant to footwear condition. This may have influenced subjective scoring.
They actually noticed the point that I made, and I'd forgotten they'd done this, that the distribution of data was greatly variable, and that they could have reduced this possibly by increasing the sample size. So it was actually a really critical point that the reviewers have made regarding sample size, because in so doing they might have got a much closer set of data.
Yes, I see that further down the paragraph. Okay, I'm with you. Distribution of data between participants show great variability. Okay. Increase the sample size to what?
Well, you'd need to power that for the effect size and set the alpha and the beta.
Sorry?
You would calculate that according to the effect size you were looking for, and you'd set the alpha and the beta levels, and you'd work with data that has already demonstrated a similar effect. I see. You're looking for to do that calculation.
Okay. This study could be a useful premise for the development of larger scale structured clinical trial to explore the material properties and construction of the shoe in relation to pathology. So perhaps breaking it down, different materials, looking at different specific pathologies. There's a huge area to mine for future researchers. What they've just said there, I would say. Future research would benefit from analysing the effects of the footwear on participant-specific foot pathologies, anatomical variations, and I would certainly think, Hals valgus and hammer toes and stuff would be right up in top of the list for that, wouldn't it? And gait patterns, velocity, and body weight. So a variety of different things to look at in the future. Suggesting that this could be a useful treatment in the future. Well, I think that's pretty much all the questions I have. Any final thoughts on this? He says in an attempt to keep Journal Club on time. Any final thoughts on this research? What summarised? Did you like it? What do you think?
I liked it, but I have to say, because Emma's here, I'll say that I actually read what she wrote because I recognised your name, so I've read what you'd written, and it has sort of impacted on my thoughts about the final article, because there were areas where it felt as if the people writing it were perhaps saying things that weren't quite supported in literature or not saying things that were supported in literature, and it was just interesting what somebody had written about it, which they, I assume, have altered, did make me think about.
So this relates to the open access peer review system.
Yeah.
Which, it's an
bad?
interesting system, isn't it? Is that, Emma, is that particularly common? I've seen this before in the Journal of Foot and Ankle Research. I'm not aware of it in other journals. Is it common to other journals?
It's increasingly common, and there's now a new sort of, I don't know what to call it, a website or a facility, an online facility where you can actually collate all your peer reviews. So that when you go for your promotion, then you can just show how many articles that you've reviewed, and it'll take you straight back to them. And the open access system, like you say, it's extremely transparent. So I can't remember at the time whether I was aware of who I was. I don't think I was aware of who I was reviewing at the time, even though they knew who was reviewing their paper. I don't think that I knew the authors that I was reviewing, because I possibly might have not. What I'm saying is I might have chosen to not review it in this case, just because of declared bias, really, because, you know, I know these guys personally. So I'm quite glad that I didn't. Looking at the phraseology I've used, I think it was as if I was addressing somebody I didn't know. In hindsight, this was quite a while back, I think, when I was reviewing it, so I don't have a clear memory. But I'm also glad that I can see the other reviewers' comments as well, because you review in isolation and you don't know what other people are making of the same paper, the same script that you're reading, with a view to publication. So when you go back and see, and I've read the other reviewers' comments as well, and I've also looked at her background, Karina Price at Salford, and she's not a podiatrist. She is somebody who's got a sport and exercise rehab background. So I think looking at between the two of us, her PhD is very much looking at non-clinical measures, although she's got a similar sort of field of study. So I think there was a nice blend of sort of approaches coming into the peer review commentary there, and I'm quite satisfied with it. When you look back at it in hindsight, it looks like a very robust system that they went through.
Yeah.
Yeah, no, that's good. Well, it's an interesting system, and it's quite nice as a reader rather than reviewer to get a wee bit of an insight into what's going on in the past. But I think what you were saying there is it sort of colours your reading of the article as well a little bit. If you do take the time to go and read those comments. I didn't really get a chance to read them. I only clocked last night, Emma, that was the case at all. I picked the article by sheer coincidence. I picked an article that you reviewed. So I almost slightly regretted that at that point. The kind of final question was, will this change your practice at all? Now I'm going to start, because I'm going to say no. Because it really is not going to make any impact on me directly. But I think what Emma said earlier on is certainly true, and it may well impact on practice in other areas for other people. So for that sake alone, I think it's to be welcomed, isn't it? And I think, you know, we watch to see what happens in the future if they continue this line of inquiry, or if others take it up. It'll be interesting. But it was a welcome, for my money at least, a welcome addition to the research in this area. So what about yourself? So I'm gonna throw up the final slide before we cut back to the room here. But did you enjoy the article? Do you think it will change your practice in the future, potentially?
Well, I think it's good. It would be good to know if these types of footwear did make a difference, because so many people aren't wearing the right footwear.
But you also don't want to recommend something if you don't have something to back, literature to back up to say that it has been found to be effective, especially when people are having to put money out. So you want to.
We've seen the other side, haven't we? All the people that are in terrible pain from the wrong choice of footwear or poor choice of footwear or inadequate footwear for whatever reason. Yeah, indeed. Emma, what about yourself?
I don't think it'll change my practice too much, because I think as an experienced podiatrist, I'm fairly clued up about spotting the signs of pressure both in the shoe and the foot, and according to the patient reported pain that they have experienced associated with footwear. And I poke for it until I get the information I want. But I guess in terms of perhaps neuropathic patients who have a new pair of shoes where you don't see the signs until it's almost too late, this might be a useful adjunct to practice to help us to select the right shoes in the first instance.
Okay. So now I've thrown up on the screen. I don't know if anyone can see that, of course, but the date of the next meeting is Thursday, the 13th of April, as usual, trying to aim for between 5:30 and 6:30. So I'll just throw that out there before I kill the camera to the slides. Now, it's one of these annoying trackpads on the laptop, so I'm trying to navigate my way around the screen. There we are. Right. I'm back. Hi, I can see you again.
Hi.
So that was good fun. I enjoyed reading this article, the medical grade footwear, the impact of fit and comfort from Journal of Foot and Ankle Research. I'm glad you all enjoyed it as well, and took the time to join us for the Journal Club. We have one more session of the 2016/17 calendar, as I've just said, in April, and I'll send out details of the paper in due course, but hopefully you'll take the time to join us again for that. It's always good fun. Everyone enjoy Journal Club?
Yes, very much.
Yes.
I enjoyed Journal Club, and I did try and get the undergrads to come along to this one. Some of ours are on placement. I did also nearly kill the first years with enthusiastic biomechanics teaching today, so I don't blame them for not turning up.
All right. Well, we look forward to seeing you again in April. Thank you.
Thanks so much.
Bye.
Have a nice night.